Hello friends, in the sequence of ENT lectures, we are continuing the today's class from the previous lecture, or we can say that today's class is the extension of the previous lecture, which is CSF rhinorrhea. CSF rhinorrhea is also called as CSF leak, and in the previous class, we have managed to discuss about some etiological factors which are responsible for a CSF leak or the presence of a CSF from the subarachnoid space into the nasal cavity. There are variety of routes engaged or involved in the process of leakage or the leak. And in the previous class, we have discussed that. Today, we are going to discuss about which testing or which are the diagnostic parameters or diagnostic techniques which are used in clinical practice in order to delineate in the sense is to locate precisely where the location of the leak actually is. So let me take a pen option, and we already discussed in order to have some kind of a revision, the ethmoidal complex or the ethmoidal plate, which is a very weak structure, which is also called as anterior skull base. Anterior skull base is a weak in by the virtue of presence of various olfactory filaments or nerve fibers, which takes an entry from the anterior cranial fossa into the nasal cavity, into the olfactory region through this cribriform plate by having various openings into the ethmoidal roof. So this is the most comprehensive and the most common route of a CSF leak from a subarachnoid space. Apart from that, in order to have a leak or a CSF leak, you have to have some kind of a dural tear as well. Dural tear, so that there will be the leakage of this CSF through this dural tear, and the bone fracture is there. So perichondrium is also ruptured, and the CSF is presented into the nasal cavity. The second common route is through the frontal sinus. The posterior table. This is the posterior table. This is the anterior table. So the fracture of the posterior table leads to dural tear, and this dural tear, apart from the arachnoid dissociation or rupture, the CSF is presented into the frontal sinus, and then the nasofrontal, through the nasofrontal duct, this CSF is presented into the middle meatus. Middle meatus is a groove underneath the middle turbinate. The middle turbinate is highly convoluted and it's a complex structure because anteriorly it is attached to the ethmoidal roof or anterior skull base. The middle part of the middle turbinate is attached to the orbital plate, which is called a lamina papracia, and the posterior part is having some kind of a articulation with the this horizontal plate of the palatine bone. So it's a free end. The posterior edge is free. So the CSF through the frontal side, it leaks into the frontal side and then comes into the nasal cavity via the nasofrontal recess. The third one is, and it's a rare kind of a route in which the CSF is presented into the sphenoid sinus, and through the sphenoethmoidal recess or opening of the frontal sinus, the CSF is presented into the nasal cavity. So these three routes are quite common, and in these three routes also, the cribriform plate route or anterior cranial fossa route is by far the most common because of the presence of a thin plate of bone which has to be disintegrated in order to have a CSF leak. My name is Dr. Atul Bhardwaj. I am faculty in Chaudhary Brahm Prakash Ayurvedic Charak Sansthan in the capacity of assistant professor. I will also like to request here to subscribe my channel also in order to have some videos of ENT, even some surgical videos of endoscopic ear surgeries are available on the channel itself. So we have discussed the two types of CSF rhinorrhea. We have already discussed in the previous class. First one is traumatic, and the second one is spontaneous. Traumatic, as a as a result of either a surgical trauma. Surgical is a iatrogenic trauma. Iatrogenic is which is essentially associated with with surgery or a post-surgical trauma, you can say. And non-surgical traumatic is like in a case of a road traffic accident. So this is essentially a CSF leak which is associated with some kind of a trauma. Even the surgeries, particularly of the you can say the pituitary fossa surgery, which is nothing but the adenoma or a microadenoma or a macroadenoma surgery. Apart from that, olfactory fossa surgery or other carcinomatous surgery, in order in which the bone has been drilled, and the chances of this CSF leak are there. In case of a road traffic accident, the multiple fractures of the facial bones, particularly the ethmoidal complex, and apart from that, the Lee-Ford fractures also. The Lee-Ford fractures. Lee-Ford fractures are a classification of facial fractures, and it also involved the fracture of the ethmoidal frontal and the sphenoidal complex. So but then this spontaneous class of CSF leak is an interesting presentation, because there is no trauma in these case, and these patients presents with the dripping of a clear fluid into the from the nasal cavity. And these patients, essentially many of the cases, has got a high pressure. Our CSF pressure is high, but it can also occur in a case of a normal pressure, or even in a case of a low pressure of the CSF. This happens to be because there may be granulation in the region of the subarachnoid space, or even in case of osteomyelitis of arachnoid granulation, or even the congenital dehiscence in case of a bone dysplasias. The inherited you can say breach in the continuation of the bone, or also called dehiscence in the bone, leads to this kind of a leak, which may be present, especially if the patient is having abrupt increase in intrathoracic pressure, which leads to increase in the CSF pressure, like we do in a Valsalva maneuver. So these patients presents without a trauma, but there is a CSF leak. Essentially, the traumatic leak needs no treatment, and the chances of self-healing are quite high. Self-healing will be there. Self-healing will be there. But in case of a spontaneous CSF leak, surgery is primarily the only option which is available. And let me discuss about some surgical approaches. So traumatic, we have already discussed. We have already discussed the iatrogenic, like in a case of a transsphenoidal hypophyseectomy, that is a transsphenoidal, transnasal, you can say transnasal transsphenoidal pituitary surgery, or in a case of a NTA skull base tumor, or the tumors of the olfactory groove. They may lead to some kind of a breach in the continuation of the dura, or dural rupture, and hence the leakage of CSF is there. So spontaneous, as I've already discussed, in case of a tumors or a pituitary tumors, they may causes a demineralization of the bone. And even a case of a osteomyelitis, that is inflammation bone marrow, there may be a CSF leak because of the disruption of the integrity or the continuation of the bone involved, especially the frontal bone and the ethmoidal complex or the ethmoidal bone. So diagnostic approach, we have already discussed that it's a as a in a strictly speaking, in a clinical sense, when the patient presents with a clear watery nasal discharge without having allergic manifestation. If the patient comes without a sneezer and thin and watery nasal discharge, itching in the nasal cavity, and the patient can show a reservoir also. Reservoir sign is when the patient is held in a leaning back position, then the CSF, which has been leaked from various roots, are collected in the nasal cavity, and suddenly the patient is bent forwards, and there will be dribbling of, or the CSF presents with a gush, with a force, this thick, thin and watery discharge or CSF comes with a force. This is called a reservoir sign. Reservoir in the sense is you can make the nasal cavity reservoir of the CSF for some time by bending backwards, by collecting some CSF, and if you bend forwards, then suddenly with a gush, the CSF presents through the nasal cavity or anterior nasal aperture or nostril, you can say. And this is a very good clinical appreciation in the sense is this is a very good clinical observation which may suggest the patient is having a CSF leak. But this is not the only test you should do for the diagnosis of CSF rhinorrhea or CSF leak. You have to go under, or you have to to recommend some diagnostic tool in the form of CT scan or a myelograph or a MRI. All these tests has got certain advantage and disadvantage attached to it. Most commonly, most of the patients, because the nasal cavity is surrounded by bone, and they have got a hyper intense shadow in the CSF, in the CT scan. So a high resolution CT scan is for me is the diagnosis of choice for the diagnosis of CSF leak. You can actually determine what kind of a source the patient is having and what the location of the fracture is. So also, the glucose content in the nasal secretions are way less than the CSF. So even you can use this dextro sticks, which are commonly used to detect this glucose or sugar content in the urine. They are even used in the nasal secretion, and because nasal secretion has got the this sugar content about 10 mg per dl, and in case of CSF it is elevated to about 50 to 66, and blood sugar is in a fasting is less than 100. So the presence of higher amount of glucose in a nasal secretion is again suggestive of that the patient is not having this as a nasal secretion but as a CSF. So we also, but the most comprehensive test, most accurate test you can say for the diagnosis of whether the patient is having a CSF leak or it's a nasal discharge is the presence of beta transferrin, beta 2 transferrin. It's a costly test actually, and the beta 2 transferrin is an enzyme which is only present in internal ear or perilymph, and as a aqueous humor in the orbital, in the eyeball. So this beta 2 transferrin is only present in aqueous humor or a perilymph and a CSF primarily. So the presence of this beta 2 transferrin in a nasal secretion virtually rules out any other pathology, and you with certain amount of conviction say that the patient is having a CSF leak through the nasal cavity and nothing else, because the presence of aqueous humor and perilymph are a remote possibility. The chances of having these two presentations are only bookish. So not even bookish, you can say. So uh, now we will move on to the neuroimaging, or what kind of a diagnosis you can do in order to accurately locate the leak location. So a CT scan, a fine cut is about 3 mm to 5 mm cuts of a CT scan, both in a horizontal and a vertical section, or you can say in a axial section and a coronal section in is used with a 3D reconstruction. In order to do a 3D reconstruction, you have to by presence of a software, you can combine all the axial and coronal and sagittal sections in order to form a complete three-dimensional anatomy of the structure. So this is now widely available in most of the centers which are having a CT scan facility. So in order to have a precise, especially this is important in case of a facial fracture or a skull base fractures, because this 3D reconstruction will give you apparently all of the details which are engaged, which are involved in a fracture, especially facial fractures. Apart from that, this CT cysternography in order to have a CT cysternography, you tend to inject a radio opaque dye into the vascular system, and this will enhance our dural sinuses, and hence the leakage can also be appreciated by the presence of this radio opaque dye with the help of a CT scan. So this cysternography is not much of been much used nowadays, but MRI along with a CT scan. So CT scan and MRI in case of a CSF leak are complementary actually. So both of them has to be done, because CT is more of a value in case of bony pathologies or bony fractures, or fractures rather, and MRI is much of a value in case of a soft tissue. So if the patient is having some kind of a prolapse also after a trauma, or a encephalocele is there, so this MRI obviously will be more significantly enhanced, or it will add up to your diagnosis, and precise location can be done with a complementation of MRI with a CT scan. So apart from that, you can even do a diagnostic routine endoscopy. Especially, you have to look for the skull base from anterior to posterior, and in most of the cases, if you do a diagnostic, comprehensive diagnostic, or complete diagnostic nasal endoscopy with a good quality of camera, you can essentially make out where the leak actually is. So MRI with a cysternography, that is again enhancement of a MRI or a CT scan with a radio opaque dye, essentially a iodine dye, or even a direct nasal endoscopy. You can visualize or make out where actually the fracture is. So let me if the staining, there you can even uh, give a you can say this nasal plagate staining is nothing but when you insert the nasal cavity with cotton plagettes, and then into the CSF via a lumbar puncture, technetium 99 labeled dye is injected, and slowly it will go into the CSF circulation. And all of you know that CSF is drained through the arachnoid villi into the subarachnoid space. So precisely these cotton plagettes will, you can say, dye themselves or stain themselves in order to correctly locate it. Let me put this point in other way. The technetium 99, which is a chromogenic dye, the chromogenic is a color giving dye, is injected into the CSF circulation, and nasal cavity from anterior skull base to sphenoid sinus is packed with cotton plagettes, cotton buds, you can say. So the if the patient is having an anterior skull base fracture or leak, then that particular plagette or cotton piece will be stained by this particular technetium 99 dye, and hence it will be helpful in actually locating where the actual fracture is or actual leak is. So this is called as a plagette test. And essentially we will take an example, but if will anterior nasal packing of this cotton plagette of anterior nasal cavity is stained, then the possible fracture will be the anterior skull base, or you can say the anterior ethmoidal loop, or also called as a cribriform plate. So as I've already told that majority of traumatic CSF rhinorrhea or leak needs no treatment, and majority of them will stop by its own, because there will be fibrosis, and this fibrosis invariably will close up this leak, or this you can say dehiscence, and invariably the patient will not have to undergo some kind of a surgery. But in case of apart from that, you have to also remove some CSF also in order to reduce the CSF pressure, so that the healing of this fistular tract can be augmented. So a lumbar drain obviously is put in place into the as a spinal tapping method, and CSF is withdrawn, in order to reduce the pressure, in order to give some time the patient for healing. For as far as surgical intervention is concerned, these patients are essentially the patients which are having a spontaneous CSF leak, because the chances of having a purulent meningitis or a bacterial meningitis is up to 30% in a year. So essentially all of the this patients which are having a spontaneous leak with non-traumatic leak has to be repaired either with an endoscopic approach, which is by far the most common approach done throughout the globe, and other the second approach is intracranial approach. You make a window into the skull, and then you lift up the brain, or you do give traction to the brain in order to expose the bone or the fracture which is involved, or the area which is involved, and then you repair it through intracranial approach from superior. But this endoscopic approach, it's a versatile approach, and uh, done almost all of the cases can be repaired by this endoscopic approach, and variety of techniques are used. But in a nutshell, I can say that the various kind of fascias, including temporalis fascia, fascia lata, and other fibrous material or sheet-like material are used. Apart from that, a cartilage, you can say buttressing in the senses, reinforcement with a cartilage, maybe a conchal cartilage is most commonly used. Conchal cartilage, nasal septal cartilage, these are two cartilages which are comprehensively or commonly used in order to repair. Apart from that, artificial glue, which is also called as fibrin glue, is also used in layers. So this is not a single layer repairment. So in order to completely repair or having a more success in repair, you have to repair the leak in multiple layers, and from towards the dural side. From the dural side, in you can say that you have to insert the cartilage as a roof into the leak, enlarge the leak, because it's very difficult technically in order to only put something like a fat or a fascia or a cartilage and then a fibrin glue on the leakage. It will, the leakage will, or the pressure of the CSF will take out all the dressing or the reinforcement which has been done. So something has to be tucked inside it. So that has to be tucked. If you make enlarge, or you in order to do that, you have to enlarge the area. You have to do a complete ethmoidectomy in order to look at that area, and you have to use some bipolar cautery, which is a very essential tool in most of the cases, and you have to repair it in layers. That is introduction of the surgical part of the CSF repair. Most of the repair in throughout the globe are done nowadays endoscopically, and with the help of endoscope, and various graft are also used, plus minus glue, or a glue may be used or may not be used. And the essentially the fundamental the principle of surgery is you have to expose the area completely by a complete ethmoidectomy, and then you can use a bipolar cautery, and then you can repair or reinforce the leakage with various grafting material apart from glue. So this is a intracranial approach in which the patient has given is done with some window. The window is made and the brain is given some traction, and the leakage is repaired. But obviously there are various disadvantages for the intracranial route, including the mortality rate, or the morbidity is also a concern in case of an intracranial approach. But the closed approach, endoscopic approach, is most of the centers are using nowadays. So this is it for introduction of this CSF rhinorrhea. We will start the Indian system of medicine, the Ayurvedic counterpart, in the form of nasal disorders, which are enlisted in our literatures or in our scriptures, particularly in Sushruta Samhita, from the next class. Thank you very much for watching the video. Thank you very much.